A very, very precise and very meticulous surgeon, Dr. Deepak MEGUR. You must watch his videos, the way he does the surgery. He's never in a hurry, very slow, very precise, and you have to watch his movements and the way he moved within the capsular bag or within the anterior chamber. So we're going to talk on no capsular support, innovative CT plan. No, this is Deepak is no capsular support. No worry, my choice is iris cloud lenses.
Thank you, sir, for the introduction, and thank you, Master sir, for the opportunity. I'll be speaking on iris cloud lenses and sharing few practical tips here. And this is one such case where it was not possible for us to save the bag, and we have an intercaps extraction done. No, it's not playing, it seems. Just a second.
Saurav has given very practical tips how to manage the PCR, which lens has to be implanted. The first important thing is every anterior segment surgeon should know the antivitrectomy. This is very, very important. We are SSCC, we are teaching for long time this antivitrectomy. Every anterior segment surgeon should know. Vena Caesar to cut the vitreous coming out, his time has gone away. It is ridiculous now to use the Vena Caesar to cut the vitreous. Never in a hurry. If you have any trouble, any itching, better to stitch the wound and send to the retinal surgeon. But never use the Vena Caesar, go inside and do the manipulation. But will make more difficult for the retinal surgeon.
Okay, this is the case where we are having extreme degree of zonular laxity, and we had to do an intercaps extraction. The first step which I did was push in OVD so that we don't have vitreous prolapse. So it's better if we can fixate the lens before doing an anterior vitrectomy, simply because the eye would not be so soft. So if possible, in trying to do a intercaps extraction, do it in such a way that we don't disturb the anterior phase, as was in this case. So visco expression is one of the better options to do that. It is done now. So now we're going to use the diluted pilocarpine to get the pupil into a slightly mid-dilated position. We're sliding in the iris claw lens and placing it in a horizontal meridian. Now, just a moment here, look at the incision here. This is the incision which is optimal. This has to be short, posterior limbal, and this is the incision which was, it is not ideal for the iris claw lens. It has got a long intracorneal tunnel. Very difficult to maneuver your cannula when you're doing this. So ideally try to avoid it. So better to stay in your incision locations beforehand itself if you're planning it from beforehand. Now arrange this, and then you're going to use the forceps to stabilize the lens first. The other option would always be to introduce your second instrument beforehand itself. Now, the location at which it is being held is important. That's what I prefer. It has a notch here in the peripheral part. So the haptic should correlate with the notch, so that when this haptic goes behind the iris, we are blinded, we don't know where the notch is. So we are guided by the location of this so that we can push the second instrument to achieve the inclination. So that's the idea here. So you're holding this, and now it is slid under the iris now. So this is what it should correlate with your notch. Then you're trying to go behind it. And now you're negotiating the second instrument to it. And once you go and press it, you can see a small dimple appear there. And because it is just exactly near my incision, I didn't have to travel much. And you just confirm this by pulling the lens a little bit. The iris should move along with it. I'm just trying to show the same movement. You move it along. So this ensures that the inclination is true and perfect. So many people are worried about dropping the lens down because of improper inclination. This is one quick test to do that. You may refill the chamber and then do the same maneuver again. Now, because this tunnel is slightly longer, you can see these corneal folds that obscures visualization. So always ensure that you plan your incisions appropriately. The amount of iris tissue which gets enclaved actually it will determine how round the pupil or how oblong the pupil is going to be. Most often than not, it would be, cat's eye pupil will develop in many of our patients, and I prefer to do an iridotomy with the cutter itself after placing the lens, or you can do it before as well. Now, in this case, because I had not done the vitrectomy earlier, I'm doing it later on. I prefer to use the IA cut mode. We just engage the iris, 1 or 2 cuts, and then it's gone inside. Then I go behind the lens and then perform a limited anterior vitrectomy. It also helps us to remove all the OVD behind. And it's mandatory that you do a vitrectomy and you don't leave any vitreous fibril there. So a residual vitreous fibril is probably the more important cause for a CME in such situations. So be mindful of that. Another case of a microspirophakia. And again, this is a technique of doing an intracapsular extraction just by using viscoexpression. Place it, don't use a vectis or a dialer, because there is always a risk of incarcerating the vitreous in between the vectis and the nucleus, and that is going to cause traction on the vitreous base. So this is a preferable way. And once you're done an iridectomy, pupil has come down, again you're going to slide in your lens, and again arrange it appropriately before attempting to enclave. So the forceps which I prefer to use is the Clayman iris claw lens folding forceps. It is much more thinner than the traditional iris claw lens forceps. So you don't lose the chamber much because the wound opening is minimized. So that's the reason why I prefer this. And once again, the way you're holding, I feel this is very critical. This is how I prefer to teach, that if you can position in such a way that you have an idea now. Once the claw goes behind the iris, you know where the claw would be. Then I'm going to use a 26G cannula. And why not a Sinskey hook? Why a 26G cannula? Simply because if you use a Sinskey hook, it is relatively sharper for the stroma, and you're going to perforate and cause an iris hole. That's the reason why I prefer to use this 26G cannula. And I learned this tip from Dr. M.S. Ravindra. He was the one who was using this cannula, and this is all. And you can see this pucker appearing on the iris, and that suggests that your enclavation is done. You can always go ahead and reconfirm it and ensure that the iris is moving along with the movement of the lens. That should confirm that the iris is being tucked reasonably well enough. So there is a recommendation that you can suture one haptic so that you don't lose the lens into the vitreous. But if you can follow this step and confirm that the engagement is true, if you're not confirmed, then again redo the thing or pull the lens out and again go back. So don't leave the lens until you confirm this aspect. So in this case, again, this is being done before vitrectomy. That's the reason why the visibility is very good. And you can see the intracorneal length is very short, and the cannula is going inside now. And you just go one stroke, you see the dimple there, and maybe you can always go in and do another stroke. So you can see these dimples, and it is very secure. So now is the time we can remove the OVD. And many times when you're done a vitrectomy and you want to remove the OVD, it might be difficult for you to go through the two side ports. So in this situations, typically we recommend to do a bimanual entry always when you're doing vitrectomy. This is one situation where vitrectomy has been done to remove OVD. You can always go through the main incision.
Deepak.
Yeah. So with that, I think I'll conclude my talk. Thank you so much for attention, sir.
So Deepak has made this iris claw lens so simple in his hands. So we can try, we are doing the SSCC also, this iris claw lens. You can come and try there also if you have any hesitation. But